without further ado, I'm going to move on to our next fantastic panelist, Rahul. From lovely Puerto Rico. I think we should have all had this conference in person with you there. That would have been my preference. So Rahul, will you tell us more about what you're going to talk about today?
Sure, yeah. I'll start by just saying thank you to you, Caitlin, for moderating, and to Jen and URI, Center for Nonviolence and Peace Studies, and to Eric and Beth. It's really a pleasure to be here, and I'm excited to share a little bit about housing from my perspective as a primary care physician and addiction medicine physician who practices in Providence, Rhode Island, and also does street outreach with a local nonprofit organization in Rhode Island. And so what I'd like to talk about today, and that introduction by Eric was so wonderful, and I think creates context that's very useful. And I think in particular, Eric's focus is on high level sort of policy changes and advocacy, whereas my role in the system as a physician who sees patients on a one-on-one basis is more about what we as healthcare providers and as health systems can do with each individual patient. So I'll be shifting the focus a little bit from higher level to slightly lower level, understanding that both forms of advocacy need to take place in parallel. And so today what I'd like to share through an anecdote about one of my patients is the role that health systems can play in supporting individuals' housing status and other housing needs. And so I'll start by reading off a story that I've written for this presentation. One afternoon in January in a community health center in South Providence, Mr. D buried his face in his hands and gently declared himself as good as dead. His mother, the center of his universe, had transitioned to hospice earlier in the week. Just as he always had, Mr. D was working tirelessly to meet all of her needs, even as the goal of his care had evolved from keeping her alive to helping her die. They lived together in her subsidized one-bedroom apartment most of his adult life. In fact, she'd added him to the lease just a few years earlier because of his dual role as son and caregiver. However, his life was now on the verge of being appended because the subsidized building in which they lived was intended specifically for elderly individuals and people with disabilities. Mr. D was considered neither, and thus he would have to relocate after his mother's death, in spite of his name being on the lease. His criminal record, race, and lack of income all stared him in the face, as if daring him to so much as try to submit a housing application. He understood that on paper, he was a landlord's worst nightmare. Housing insecurity, as Eric pointed out, is one of the most common social risk factors impacting health in the United States. And a growing recognition of this fact has led some health systems to take a more active role in trying to address patients' housing needs. However, housing insecurity isn't just a matter of circumstance. It's a condition that exists because of the dual and intersecting forces of racism and capitalism. This makes housing advocacy and support very daunting for healthcare systems and providers like myself alike, as neither can single-handedly shift social policy. Health systems have found some success in using housing as a health intervention. And by doing this, they've had to, in some sense, bypass existing social structures by directly housing their own patients through investments in housing stock and or payment of subsidies. A more common strategy, however, has been to just screen patients for housing insecurity and then refer them out to social service agencies, like the local one that I do outreach with on a weekly basis, or the one that Caitlin Mary oversees. And while this is an incredibly well-intentioned approach that may work in communities with a highly organized and well-resourced homelessness and housing services field, often more than not, it's just passing the buck from a health system to social service organizations, which are often community-based nonprofit organizations, who also have to contend with the realities of a housing system shaped by racism and capitalism, lack of affordable housing stock, lack of permanent supportive housing, stigma from landlords, and so on. Health systems will eventually have to contend with the limitations of this screen and refer out to others approach, especially as many begin to invest in private software programs meant to facilitate this very process. But there are other paths to consider that are immediately actionable, and immediacy is important in light of how many health systems are eager to be responsive to today's calls to focus on health equity and anti-racism. Existing models of addressing housing and health settings have largely left out the healthcare provider, reifying the misinformed notion that consideration for all of the structural determinants should fall only on other disciplines, whether it be social workers, community health workers, nurse care managers. The healthcare provider's role has been relegated to one of intermittent screening at best in current models, with a focus on the social determinants of health. But we as healthcare providers are in large part responsible for this gap. The traditional role of the healthcare provider has been to focus on narrowly biomedical aspects of care. However, when clinicians fail to understand and acknowledge the holistic context of a patient's life, it often results in discordant goals between the patient and the healthcare provider. For instance, consider the scenario in which a patient has a significant spike in their blood sugar level that because they're experiencing numerous obstacles to managing their health and can't consistently take their insulin. As the healthcare provider sits against the wall of the examination room, scrolling through glucometer results, they may feel like the only tool available to them is to up-titrate the patient's insulin, even though it's clear that the patient hasn't been able to take their insulin in the first place. The healthcare provider makes the recommendation to up-titrate the patient's insulin anyway, and this pattern may continue for years. Eventually, the patient may stop showing up to appointments because they feel like the healthcare provider isn't willing to consider their most pressing priorities, so there's no sense in continuing to engage in care. The healthcare provider may feel disempowered by the lack of progress they were able to make with the patient, yet they continue to narrowly consider their other patients' biomedical needs because they don't know how to contextualize the care they provide. Contextualizing care is central to providing care to patients because it broadens the role of the healthcare provider from one that's strictly biomedical to one that considers the whole patient. This is an evidence-based approach to caring for patients that results in improved healthcare outcomes with a number needed to treat of 6. And it provides both a conceptual framework and a practical evidence-based strategy for identifying and addressing challenges that are relevant to planning each patient's care during a routine medical encounter. It consists of a 4-step process that's quite basic. First, as your patient's talking to you, recognize clues that the patient might be struggling with factors in their lives that are complicating their ability to manage biomedical aspects of their care. Second, ask high-yield questions to follow up on these challenges. Third, identify opportunities to intervene. That could be as simple as sitting there and bearing witness. And fourth, incorporate the information into an individualized care plan. Remarkably, this approach, contextualizing care, doesn't lengthen the visit, but does improve all sorts of outcomes. Going back to Mr. D was one. I'm going to lose my mother and I'm going to be homeless, he explained, burying his face further into his palms. His next sentence was barely intelligible as he worked to gulp back the sobs. I don't know what to do. Before the physician shifted her gaze from the computer screen to fully focus on Mr. D, she noticed that his point of care sugar had returned high at 10.2%, a substantial bump from the prior quarter. She'd entered the room intent on discussing Mr. D's diabetes control. However, it was now clear to her that the agenda she'd constructed wouldn't align with Mr. D's goals. So she pivoted, choosing instead to practice evidence-based medicine by contextualizing the care she provided. Mr. D, I'm sorry. I know how much your mother means to you, and she's been so lucky to have such a caring and loving son. After allowing for a few seconds of silence, she sought to address the agenda she knew they would share: housing. The physician began with a simple question. Do you want to stay in your mother's apartment after she passes, or would you rather move elsewhere? One reason that healthcare providers often give for not attempting to elicit contextual information is that they feel that doing so is futile and that they likely won't be able to help much anyways. The societal level causes of structural racism, poverty, other drivers of inequity can leave healthcare providers feeling helpless and resigned to focusing on the narrowly biomedical aspects of care. That is, however, completely at odds with how society is structured. There are numerous examples of invaluable social resources that can be unlocked for patients with the input and signature of a healthcare provider. However, education about these resources hasn't been integrated into medical education, much less the current framework of anti-racist medicine and health equity. The hegemonic notion that physicians, physician assistants, nurse practitioners should not engage in the provision of social care has meant that most healthcare providers never learn about the immense power that federal and state governments have conferred to them. The major exception is when a clinical site receives support from, for instance, a medical legal partnership. Medical legal partnerships entail embedding civil legal aid experts in the healthcare team in order to identify lapses in protection of patients' civil rights and engage healthcare providers in appropriate interventions. And related to Eric's point about criminalization, as a high prevalence of correctional control among under and uninsured individuals engaging in healthcare is increasingly acknowledged, there's also been a push to incorporate criminal in addition to civil legal needs into medical legal partnerships. However, while medical legal partnerships have been shown to improve a variety of social outcomes and decrease acute care usage, they can be resource intensive and thus only serve a very small percentage of the US population engaging in healthcare. Scaling the invaluable knowledge that medical legal partnerships bring to the health system about the power of medical documentation requires that healthcare providers learn about and embrace their own role in the provision of social care. Of course I want to stay in my mom's apartment, Mr. D exclaimed. It's subsidized housing. I would be crazy to leave. You know I don't have any income. As the physician nodded in affirmation of his decision, she printed and signed a standardized federal form intended for healthcare provider use entitled U.S. Department of Housing and Urban Development Verification of Disability. The entire form took less than 3 minutes to complete, print, and hand to the patient. She handed it to him. Mr. D, this form will allow you to stay in the apartment after your mother passes. As you know, I've supported your decision to apply for disability for years, but because you haven't been awarded disability by the Social Security Administration, you're not currently qualified to live alone in your mom's subsidized housing complex. This form's a way around that. By signing the form, I'm using my clinical judgment to declare you disabled for the purpose of the U.S. Department of Housing and Urban Development, because we know that there are many people such as yourself who could benefit from these services that the Social Security Administration currently misses. Mr. D called the clinic later that night in tears. He'd wanted to thank his physician for caring for both his health and his social needs. The management office at his subsidized housing complex had accepted and approved the form. They stated that it was very helpful to have supporting clinical documentation from a physician. Mr. D's mother's death remained imminent, but he would no longer become homeless as a result. This anecdote about Mr. D is just one example of how the health system can directly influence housing in a patient's life. There are many more examples, and our interdisciplinary team here in Rhode Island has sought to compile all of them in one open source platform called docsforhealth.org that we've created in partnership with a local law school called the Roger Williams University School of Law. And I will share my screen here for a moment just to point out some of these examples for on the ground advocacy at the health system level. So here at docsforhealth.org, after clicking on forms and letters and then clicking housing, you'll see that there are a number of resources or tools that are unique in that they require the input of a healthcare provider and the signature of a healthcare provider, and then reflexively unlock certain social resources for our patients. So we talked specifically in the anecdote about the disability housing preference, which is based on a federal form. Many of you have probably heard of the reasonable accommodation request, which requires standardized federal language and is written by physicians for patients when their health needs have changed and they need there to be an accommodating change in their living environment. So that could mean, relocating to a ground floor because they've newly undergone an amputation, or getting something as simple as carpet changed out because of asthma exposures. One of my favorite resources on this site is the poor housing conditions resource. So as I talked about in the anecdote, all too often health systems farm out these types of structural problems which directly impact health to legal aid organizations, medical legal partnerships, or community-based nonprofit organizations, all of which play critical roles, but all of which also tend to be oversaturated. And so for cases that are more direct, less complex, require less nuance, there are resources that have been studied, such as a poor housing conditions advocacy letter. So as an example, in the Journal of the American Medical Association, in around October of last year, a study was published that surveyed 5,000 patients who came into 3 different primary care clinics throughout New York City. And they asked 2 questions. The first question was, are you currently struggling with any poor housing conditions? And then they provided examples, rodents or broken light fixtures or anything else. And the second question was, if so, would you like your physician to write a letter addressed to your landlord that you can take back to your landlord with you today? And if patients answered yes to that second question, it auto-generated a standardized letter that required very little to be filled in by the physician. And a month later, approximately 89% of those patients said that their landlord had begun to rectify the issue, and 77% said the landlord had completely resolved the issue. So for those of you who are familiar with low-income housing, subsidized housing, and the state of sort of maintenance affairs in those types of complexes, taking only 1 month to fully resolve poor housing conditions is quite remarkable and speaks to the social responsibility and power that physicians can have in our society when it comes to housing. So I will leave it there. Thank you so much.
Thank you so much, Rahul. That was a wonderful presentation. And I did, for anybody that linked while you were showing that screen, I did put the link in there. And the story too, I love when we can center these conversations in the real story. So I love that you included that, and really was practical, but it was also moving. So thank you so much, Dr. Vanjani.